Great. Okay, well, thank you all very much for coming, especially in the summer. I'd warned him to expect no more than 10 or 12, so this is a bonus attendance, and I'm very pleased to introduce Mirfin Mpundu, who's here from the Ecumenical Pharmaceutical Network based in Nairobi. As some of you know, I attended the meeting of their forum, which happens every 2 years in Nairobi a couple of months ago, and had a very exciting time, very interesting time. I was able to videotape a lot of the individual members of the network. Mirfin is from Zambia, and I've learned that he started as a pharmacy technician, but then Zambia wasn't teaching pharmacy, so he went to Dar es Salaam to do his pharmacy degree there, because Tanzania and Zambia had an exchange program for the School of Mines in Zambia catered for Tanzanians, and the School of Pharmacy in Tanzania catered for Zambians to make up for the lost training activities. He worked when he returned from Tanzania back to Zambia, he worked in the public sector and then private sector, and then moved to Michigan, where he did an MPH and an MBA, and ended up in Washington, where his wife works as a lawyer for the World Bank. She's recently moved to Sydney as the contracts officer for the Pacific Islands and China, so the big and the small. And that was his opportunity to return to Africa, where he's recently appointed as the executive director for the Ecumenical Pharmaceutical Network. And I've asked him to talk about the network and then opportunities for collaboration and cooperation between our department, the centre, and the broader university. And we had a meeting this morning at the Africa Study Centre, and we've also met with the faculty office, the practicum office, and Jeff Lawler in the careers office as well yesterday. So I've asked him to talk for about half an hour, maybe 40 minutes, about the program, and then there'll be lots of opportunities for questions and other discussions. I've asked Rob to videotape it so that we'll be able to use it for some other purposes as well as this presentation, and we'll talk about that a bit later. So Mirfin, you're very welcome.
Thank you so much. Good afternoon. I would like to express my gratitude that, and also to thank you for coming to listen to me from all the way from East Africa. And I certainly would like to say thank you. And I think that our discussion will be quite helpful and meaningful. Richard invited me in April. He came and presented at our forum. We have an annual forum every 2 years, and we bring our members. And we had invited him. He came and made 2 presentations, and one of them had to do on scholarship and collaborations, which drew a lot of interest and excitement among the members. And after that, we sat down and talked about possibilities of partnering with Boston University and seeing how we could actually work together. And so he extended that invitation to me, and so I'm here courtesy of him. And Joe, I think they've worked so hard in putting this whole program together. So thank you so much. He's introduced me already, so I won't go over. But to say that it's interesting in life sometimes that I always had a passion. I think when I was young that I wanted to work in the area of medicine and public health. I ended up doing pharmacy, but still I've worked both as a clinical pharmacist, a retail pharmacist. I've done projects in the public health sector. I've helped develop immunization programs. I've worked in the HIV area. So but still, I felt that my area and my passion was to actually work in a developing country. So I've always wanted to work in a developing country, and so after working here in the US, I decided in March to take up this appointment in Nairobi. And so I'm now in Nairobi. That's where I'm working. I'm working for this organization, Ecumenical Pharmaceutical Network. This organization, we are a Christian organization that is not for profit, and we work both with the Protestants and the Catholics. We are an independent organization, so we we are not affiliated to any other organization, and our passion is really in the provision of pharmaceutical services. We try to do that as a way of achieving the public health goals that have been set by organizations like WHO and some of the member countries where we work in. We are a worldwide network, and the way that our network is like, the members of our network are really in three categories. Number one, these are associations, and the associations, the churches in various countries have got hospitals and clinics and health centers. These hospitals belong to a mother body, and that mother body joins our network as a member. An example in Kenya, where I'm working from, there is the Churches Health Association of Kenya. This is the mother body of the mission hospitals or the Christian hospitals in Kenya, and this becomes our member. But we also have individual hospitals can join our membership, and we also have individuals that identify with our mission and our vision. They join our membership and become actually members. We are interested in the delivery of just and compassionate actually pharmaceutical services. That's our focus. And EPN was mothered through the World Council of Churches in Geneva. They wanted to focus on health, and one of the areas was on pharmaceuticals and actually commodities in pharmacy. Then they decided to move to Nairobi because most of our work really is in sub-Saharan Africa and West Africa. So that's how come we are based in actually Nairobi. The vision we have is to be a global partner. We try to be a global partner for just and quality pharmaceutical services. The whole idea is, we all know here that in terms of delivery of actual health care, you can't do it alone. You've got to be a partner of other groups. That's the way that we do that. And our mission is to support these churches that have hospitals and the church health systems to develop them in such a way that they can provide actually quality pharmaceutical services. And we do that in many ways. And so EPN currently, we are in over 30 countries, and we've got 88 members as of today. Most of those members, like I said, are in sub-Saharan Africa, sub-Saharan Africa. And yet we also have actually a strong presence now in India, South Asia, and the individual members are in Australia here in the States, and also part of Europe. Yeah, we have 4 focus areas that we focus on. Number 1 is access to essential medicines. Number 2, and number 1 is access to essential medicine and rational drug use. And really, under that pillar, we have a number of activities that we do. Number 2, we focus on HIV and AIDS. That's again our focus area. And there we focus on building literacy among the clergies, and also promoting the correct use of actually antiretroviral drugs and also adherence. Number 3, we focus on professionalization and the human resource development. One of the things is that, most of the people that work, in pharmacies that are run by churches are not pharmacy trained. And so we go into these institutions and provide a level of training that makes them to be able to actually practice the trade safely, and also add value in their service to their patients. The last area is information sharing. This is where we share treatment guidelines, information on drugs. We share evidence-based practices. Those are shared under that. So those are the primary 4 areas that we focus on. And I'll give some examples. Of that. Before I do that, though, it's important for us to note that that in the provision of health care in the third world countries, and especially Africa, it's provided by three groups. One is government, number two, public health sector, number three, it's by the churches. And the churches provide between 40 to 50% of actual healthcare services in Africa. And so the churches are a major player in the provision of healthcare services. And so really the churches, we are an important contributor in the healthcare sector, and we do that in a very unique way because the government normally establish hospitals in places that may be central, in places that may be political convenient for them because they will draw votes in the elections. But the churches go in the inner places, the places where actually government and private sector will not go in because it's not profitable also for them. And so really we focus on the vulnerable, those that are actually underprivileged, are not as privileged as most of the population. Yeah, so the churches play a complementary role in terms of provision of the healthcare services. We do have partners in terms of providing that healthcare services, and really these include a number of organizations like the WHO, USAID, MSH, DFAM, Action Media, because we can't do it alone. They fund a number of our projects, and I'll talk about actually how the funding is done later on. And so we work with churches, like I have said, and there's churches as actually the CHARS and the drug supply organizations to reach these patients that we try to save. These are the partners that we have. Those are the areas that I talked about. We believe as EPN, really looking at access as a focus area on its own, we believe that really every human being has a fundamental right of accessing essential medicine. It should not be something that is exclusive to only a few. And we do a number of projects to promote that access. And one of the things is that availability is one thing, access is another thing. You can have those commodities and drugs available, but not accessible if the patients cannot pay for them. Yeah. We've done a number of projects. What we did in addressing this, one of the projects that we did was, we did mapping studies, really, and those focused on looking at the presence of children medicines in Chad, in Kenya, Tanzania, Cameroon, and also Tanzania. And what we did, we wanted to find out, three things. Number one, was that are medicines available for children in these countries readily available? Number two, what are the factors that actually contribute to the availability or non-availability of these drugs? Number three, what are the pricing models for children medications in these countries? The things that we discovered was that really children medicines are really on the back burner of most of these countries and most of these governments. It's not a priority. They are not so much included in the essential drug lists in the country. Yeah, they are not ordered, and the pricing range from over 150% to over 200% market value. And so that was actually quite scary. And so like in Cameroon and Tanzania, we are now doing really interventional studies, working with government and also promoting the availability of children medicines in these countries. The other area that we work on is to strengthen the drug supply systems within the church organizations. And one thing is that actually, in terms of memberships, we have churches, mission hospitals and members, but we also have drug supply organizations. These are drug supply organizations that are pharmaceutical companies or organizations, to say, that are run by the churches to buy and distribute drugs to mission hospitals. And so we work with those to try try and build their drug supply system by looking at order quantification, ordering, supply, distribution, and all that. And one project that we are currently working on is actually called put procurement. We believe that put procurement is where churches, mission hospitals come together and say, yeah, we'll buy medications together. It reduces the cost, that's one element, but also improves on the quality because you are buying from good companies. That provides a selection, and we're doing that in Cameroon, and also between actually Tanzania, Kenya, and Uganda. The other area that we work on is quality of medicines. This is huge. Last month at the World Health Assembly, one of the major topics was addressing the counterfeit medications. There are just too many. There are too many fake medications. And what we do is that there is a product that we use in our facilities, and that's a mini lab. That's a screening test to see if a medication has got an active ingredient in it. And so we test for that. If it fails at a local facility, that's sent to a World Health Organization pre-qualified lab. And in this case, it's meds in Kenya. They will test the drug and see to actually confirm if there was any active ingredient that was just missed. That's tested, and if it's zero, then we report to the World Health organizations, and they do the follow-up and publish, this company, they approach the company, can you verify, and they do all that. But this has worked out very well amongst our facilities, and the company that we've actually used is Meds. I'll go back to this slide and just show. Yeah, that's the Meds company, which is in Nairobi, Kenya. And this is owned by Catholic and the Protestant churches. And this has got actually over now, they are doing about 100 million in terms of the turnover, doing excellently, very well. And what we did was that they started testing the drugs that they buy and the drugs that they supply. From around 1997, this is where they were in terms of the failure rate of showing that the active ingredient probably was less than what it should have been, or it wasn't in the drug itself, or probably the disintegration was not working well. And so the quality of drugs was very poor. But when you come to 2011 and 2012, even close to 2013, is that they came to actually, because they test each and every drug that they buy for distribution. And so now they are almost at zero. These are drugs coming from other mission hospitals that we send there to test. And these are showing a lot of actually failure rate. Still, it has not come to zero, showing us that there are a lot of actually quality issues on medications. Very big. This, for example, in Cameroon last year, that's an anti-malarial drug. Really, someone comes in, I've got malaria, and they're giving this medication. This, we tested that. This is the way the genuine drug should be able to look. That's fake. Zero, no active ingredient in it. The same one. This is another example, an ACT brand. Again, no active ingredient in it. Just this year we did quinine. That's an anti-malarial drug. Again, zero ingredient in it. No active actually quinine in it. So that shows, and so we focus on looking at quality and promoting quality because we know our patients are being actually short in terms of getting the correct drugs. And so that's a huge issue. And so we focus in these areas to promote them. The other area that we focus on is fighting against antimicrobial resistance. We know really, if we've been listening and reading some of the articles, really is that well, in the next 20 years, if we don't regress and address that problem, there will be no antimicrobial drugs that will be curing anything, because there's been a lot of resistance that has gone up, and the pharma industry is not producing these antibiotics at a very fast rate, because it's just not happening. We also work on workshops in terms of rational drug use, and we publish a number of things that we do. Those are some areas that we work on. Under HIV drugs is that we realized earlier on, at the height of HIV and AIDS infection in Africa, was that if these interventions, drugs, behavioral changes were going to happen, we needed to involve the churches, and these are the pastors and church leaders. So we developed programs to address the stigma, address the treatment of AIDS and HIV, and also antiretroviral adherence. We also published a few publications like this one, that addressed the literacy. So those have promoted actually the success of most of the HIV programs. It's because of programs like this one. We also do an operational research in terms of adherence, looking at the factors why the patients are not adhering to these antiretroviral drugs. The third area that we look at is building a human capacity. Those who work in pharmacies, by and large, are not pharmacy trained, because there are very few people that will go and work in a rural setting. And so we go in, we train these people. These are the practitioners in those areas. So really, we either have to build that capacity, or we just neglect them. But yeah, so we've developed a 12-week actually curriculum program, and what that does, that looks at the basic pharmacy practice, really. Ordering of medications, how do you store them? How do you quantify what you want to order? How do you actually dispense a drug? What information should you pass on to patients? Those are areas that we address really in our trainings, and we've done that. We've done that in DRC, in Cameroon, Tanzania, Kenya. Yeah, that has been done. We also have a biannual conference that Richard actually alluded to. That's one area where we bring in experts on a particular theme, and they come and talk about it. We utilize the TOT concept in our trainings, but we also offer really short-term trainings, probably for 1 week or maybe 3 days on a particular area or issue. The last area we focus on is information sharing. This is where we try to share knowledge about medicines, about diseases and treatment, and also we share information on what's happening among our members. That's one of our, that's a strong area that we use. Using the internet, writing, and these means of things. These are publications that we do, the treatment guidelines. This ePharmaLink, that's an electronic version of information on medicines, and we do that every other month. NetLink, we share information of what's happening in the network. Now that I'm in Boston here, that's one of the things that I'll be sharing on NetLink, and that comes in also every other month. And also facilities can share what's happening in their facilities so that the network knows what's going on. The Essentials of Pharmacy Practice Handbook, that's the curriculum that we've developed, and that has been used in most places. Then the Contact Magazine, yeah, that's the magazine. This we produce with the World Council of Churches has asked us to run that publication for them, and we do that for them. Then HIV and AIDS and antimicrobial resistance, we developed one innovative ways of trying to address, break the stigma, promote adherence to therapy. And we do this in a unique way by using cartoons as a way of doing it. And that has been translated into some of the local languages, and it does extremely well. 2 weeks ago, one of the pastors wrote me, I don't know him, I've never met him, I think he was writing from Chad, and he said, These actually cartoons are working great. I've used them. They are working great. Thank you so much for doing that. Yeah, so that's one of the ways that we try to communicate these harder concepts in a manner in which actually a common person on the street is going to understand. And that's one of the ways that they do understand. These are some of the current projects. I spoke about the children medicines in Cameroon and Tanzania, looking at intervention, the food procurement. Yeah. We are also working in Malawi, Chad, and the DRC, really improving the services that they offer in terms of actually medications. That's one. The operational research, I did talk about it. Publication of materials, yes, we're doing that still. And one other thing that we're working on in India and Malawi is to improve the drug supply chain. That's an issue. Stockouts are a huge issue in Africa. They are a huge issue, and so we're trying to work with the institutions to be able to actually address that area. Yeah, the other area, advocacy on antimicrobial resistance, recently in conjunction with the University of Uppsala in Sweden, there's an African group that has been formed to focus on efforts on antimicrobial resistance. One of the problems that we have done in the past when we've looked at antimicrobial resistance, we've looked at two elements, just the prescriber, over-prescribing, under-prescribing, and the availability of the antimicrobials drugs. But one of the areas that we've never focused on is that, the vets use a lot of antibacterial. Yeah. Never looked at the ecological effect. What happens in the sewer system? Really, are they treating the sewer well enough to take out those antimicrobial drugs? And so, these are the other areas that now we're looking at it in a global way, in a holistic way, and trying to talk to all the stakeholders that are involved in addressing antimicrobial resistance. So then, where do you come in as Boston University, as faculty, as students, really, how can we be able to collaborate, EPN and the members and its constituencies, and the faculty here, and the school here? There are a lot of areas that I strongly believe that we can mutually benefit from. Yeah, the Secretariat is based in Nairobi, really our head office. That's one area where actually students can come and do really a practicum, do an internship with us. The other areas are working with a drug supply organization like MEDS, the one I just showed. That's a great company, good company to work with. The other areas are church health institutions, the associations. And some of the associations are doing very well, others are not. An example, for instance, in Zambia, CHARS in Zambia, they've handled big amounts of money, really, and actually a global fund, the PEPFAR funds, over 100 million. And so, these are places really where actually doctoral students, actually master students actually can do something, benefit, really, as they improve the processes in these organizations that we have. So we've got opportunities for research, data management, analysis, really putting data together. We have so much data and research that we do, but we don't do most of the publishing. And Richard has been always telling me that, you do so much work, I've seen so many things that you do, but you don't tell your story, you don't publish it. These are areas that, we can benefit from a lot. Another area is proposal writing. We are an NGO, and an NGO has got a lot of struggles. You don't know where your funding is going to come from. You don't know if you'll be there next year. And really, most of the programs that we do, we have to source for funding. And that proposal writing is a huge piece of work. Sometimes I have to sleep late thinking what will happen next year in 2015 and 2016, because I'm thinking well ahead. And those are areas where, again, students can come, be part of it. And we can get actually all the help even from faculty on them reviewing our proposals to see really are they, because some of the organizations that we compete with, they are specialists in proposal. That's your bread and butter, and we just can't compete with them. But the other areas actually are program development. Most of these programs, we develop them based on need. And so again, those are areas. Monitoring and evaluation of programs, that's another area where those are opportunities for actual collaboration. Process improvement, those are other areas that, that's also used. Preparing papers for publication. We have tons of things we have done, which really the scientific world would benefit from, policymakers would benefit from, but we have not published them. Those are areas of collaborations, really. Informatics, really, IT support, advocacy and lobbying activities, fundraising activities, and networking. So one of the areas is, one of the things is that really a novice actually person who's coming new into the public health sector, these are great opportunities of them actually getting in without so much pressure, really. And that can be seamless way of getting involved and getting some experience in these areas of public health. Those that are experts, we've been working, again, great opportunities, new areas that actually one can be able to, let me develop another skill. And so these are areas, these can be done 2 weeks, 3 months. These are great opportunities that I'll challenge us to think about and see how we can work together. You can come in and help us reach the underprivileged, the undeserved, those that are poor. Really, these churches are doing a phenomenal work, but they don't have the capacity. They lack certain resources, and I think you would do great if you came in. Thank you very much. I appreciate it.